All right, so for this session, we are going to be talking about the ADLs and how we code that on the MDS and how it can have an impact on your quality measures as well as many other things within your facility. And the objective is going to be to identify the relationship between the MDS and the following quality measures. The percentage of residents whose need for help with ADLs has increased, and this is measured for your long stay patients. As of July 1st, 2016, they've added the percentage of residents who've had a decline in their independence and locomotion, also measured for your long stay patients. As of July 1st, 2016, they've added the percentage of residents who had an improved performance in transfer, locomotion, and walking in the corridor, and this is a short stay measurement. So some of the definitions would be for a long stay, abbreviated LS, representing an episode of cumulative days in the facility, CDIF, greater than or equal to 101 days as of the end of the target period they're using. Short stay is SS, also an episode of cumulative days in the facility under or equal to 100 days as of the end of the target period. Late loss ADLs are defined as bed mobility, transfer, toileting, and eating, and mobility functions are transfers, walking in the corridor, and locomotion on the unit. So MDS Section G is where we're capturing all of these things, and all studies show that there are more errors found in this section than any other sections of the MDS. It can impact your survey process and your 5-star rating, significantly impacting your reimbursement, can have some sort of correlation to staffing patterns, care planning, and your documentation has got to paint an accurate picture. You always want to be asking yourself, did we take credit for the care that was provided? As a precautionary measure, we want to make sure we keep telling everybody that you are not to transmit managed care assessments that are used for payment only. It can skew your numbers. So those 14-day, 30-day, 60 days are not to get transmitted for your managed care. And furthermore, when they're new admissions, we don't code them as an admission 5-day. They're coded as a standalone admission, and you use the same rules as you would for a 5-day, meaning you're not going to pick an ARD past day 8. So MDS coding has two different sections that you code in Section G, 2 categories. And so the first portion of it is the self-performance, what the resident does for themselves. So you have this whole category, this whole key of things that you can do. 0 being independent, no help or staff oversight. 1, supervision, we're giving oversight, encouragement, and providing cues. 2 is limited assistance, meaning where guided maneuvering or non-weight-bearing support is provided. 3, extensive assist is where we start to bear some of the resident's weight. Total dependence is full staff performance, meaning the resident didn't do 1 iota of that ADL. They laid there basically comatose, didn't lift an arm, didn't lift a leg, didn't put their arm through a sleeve, didn't hold a glass, didn't hold a side rail. All of those different ADLs, totally dependent. 7, activity only occurred once or twice. 8, the activity did not occur. If you code either of those 2 things on your MDS, if this is an assessment that's being used for your quality measures, they will change that coding for the methodology to a 4 to allow for comparison to other folks. So the rule of 3s only applies to that self-performance coding, all right? It only has to happen 3 times when we're talking about what the resident does for themselves. So when an activity occurs 3 or more times at any level, that's the level you're going to code. And if an activity occurs 3 or more times at multiple levels, you'll take the most dependent. So if you had 3 2s, 3 3s, and 3 1s, you would take the 3. That's how you would code it. Okay, because you're taking, it occurred 3 times and it was the most dependent. The exceptions are you can't do that for something that's coded as a 4 or an 8. 4 has to happen all the time, every day, every shift, every caregiver, that they didn't do it. And an 8 means that it never occurred in the 7-day look back, all days, all shifts, or that the family member or someone else who doesn't work for the facility provided the care 100% of the time. When the activity occurs 3 or more times, but it's never at 3 times for one level, meaning you have a couple of 4s, you have a couple of 3s, you have a 1, you have a 0, you have a couple of 2s. Then it tells you, it goes into a further description of how it is that you're going to code that. When there's a combination of full staff, being 4s, and extensive assist, you're going to code extensive assist, a 3. So when you have a combinations of 3s and 4s, but they're not enough to rise to one level of being 3, you're going to code it as a 3. When there's a combination of full staff, being 4s, combination of weight-bearing assist, being 3s, and or non-weight-bearing, being 2s, you're going to code limited assist. And if none of the above are met, so you don't have any of that stuff going on, then you're going to have to code supervision. All right, pay attention if you're using any pre-populated information coming from point-click care into other evaluations or some other kiosks that are going directly into your MDS. You want to make sure that section G is accurate before you're sending that in. So the bottom half of coding ADLs is what we did for the resident, how many people basically helped. So 0 being no setup or physical help, 1 being that we set the person up only, 2, 1 person physical assist. That means me plus the resident is 2. 2 plus person physical assist is you, me, and the resident, 3. So that's the way you can teach it to your staff for them to remember the difference between the 2 and 3. If it's just me and the resident, that's 2. If it's me, the resident, and someone else, that's 3. And then 8, the ADL activity itself did not occur or that the family members completed it. This only has to happen one time to be coded. So what the resident does for themselves, you have to follow rule of 3s. What we do for the resident, the number of people, only has to happen once in the 7-day look back. So the 4 ADLs included in the quality measures for the late loss is bed mobility, transfer, toileting, and eating. All right, bed mobility is how the resident moves to and from lying positions, turning side to side, how they position their body when they're in bed, or an alternate sleep furniture. So if you have people who have COPD or some other respiratory or other kind of comorbidity that has them sleeping in a recliner chair, that is considered a bed. We don't put 8 8s there or 7s. That's a bed. This includes lifting the legs up onto the bed or swinging the legs over the edge or helping them get to a sitting position in the bed. Transfer is how the resident moves between surfaces, including to or from the bed, chair, wheelchair, and getting to a standing position. You don't count bath and toilet, but think of how arrogant some of us are that we think we know these patients better than what the documentation says. We're right away ready to say, that's not right. The CNAs didn't code that right. They don't know. I see this person up walking all over the place. Great, you see them up walking, but that's not what you're coding. You're coding how they got to that standing position. You're coding how they got out of the bed, out of the chair, off of the toilet. Well, you don't count toilet there, I'm sorry. But you got to think about that. We can't just sit there and say that that documentation's wrong because of what you see happening around you. That's not what you're coding. Toileting, how the resident uses the toilet, the commode, the bedpan, or the urinal, how they get on and off the toilet, how they clean themselves after they have an incontinent episode, or even if they weren't incontinent, how they change their pads or manage their ostomy or catheter, and how they adjust their clothing once they're completed with that task. What we don't count is emptying the bedpan, urinal, commode, or catheter. Eating includes how the resident eats and drinks, regardless of how well they do it. We don't include any eating or drinking that occurs during a med pass. So if you're giving supplements or you're giving them pudding or any of that kind of stuff when you're doing your med pass, that's not considered. But on the night shift, 11 to 7, I worked it for 7 years. When we would give people either incontinent care or take them to the bathroom, we were giving them drinks. We have a lot of people coding 8s for people on nighttime because they don't get a meal and someone's not saying that they're having anything to drink. When you send that person to the hospital and they come back dehydrated and you try to argue that they weren't dehydrated and the hospital just said that so they could start IVs on them and get paid, they have lab work. What do you have? You have days and days of going 8 to 12 hours saying that you didn't offer them any fluids, and that's what an 8 means on 11 to 7. All right, includes the intake of nourishment by other means, so tube feeding, TPNs, IV fluids that are given for nutrition and hydration. So let's talk about the percentage of residents whose need for ADLs has increased. They've worsened, all right? They need more help. It looks at the long stay residents whose need for help with the late loss ADLs has increased when you compare it to the last assessment. Remember, we're only talking about bed mobility, transfer, eating, and toileting. It's a change measure that reflects a worsening performance compared to the last assessment. And the way they determine worsening is it's identified by an increase in 2 levels for one ADL or an increase of 1 level in 2 different ADLs. So an example would be the last assessment codes 0 for bed mobility and now is a 2. That would trigger because you've gone from a 0 to 2 up 2 points in one area. Prior assessment codes 2 for bed mobility and 2 for transfer and now codes 3 for each. That would trigger you went up 1 level for 2 different areas. Okay, and when CMS is looking at all these types of things, they really feel as though all of their staffing studies have found that higher staffing levels are associated with lower rates of increasing dependence in ADLs. Percentage of residents whose ability to move independently worsened. Again, only for your long stay, folks that have been there greater than 101 days. It's based on the self-performance coding for locomotion on the unit. Locomotion on the unit is defined as an ability to move about independently, whether by walking or using a wheelchair, in their room and the adjacent hallway. So the unit is their room. You go out their door and 1 doorway to the right, 1 doorway to the left, approximately. And that's what locomotion on unit is. Okay, a change measure that reports the percentage of long-stay residents who've demonstrated a decline in locomotion when you compare it to the last assessment. Again, decline for this one is an increase of 1 or more points between this assessment and the last assessment. So you don't got a whole lot of room for error here. All right, 1 point up is going to trigger this. So the prior assessment codes locomotion as a 1, and the new assessment has it as a 2. That's going to trigger. Percentage of residents whose physical function improved from admission to discharge. This is a short stay measure. Okay, so it's only going to look at the percentage of short stay residents whose independence in the mobility functions, transferring, locomotion, and walking increases. You actually want these numbers to be higher because it's showing an improvement during their stay at your facility. So this is a high number you want. Percentage of short stay residents with improved physical function is looking at the coding between the 5-day MDS to a discharge return not anticipated. When you're sending somebody to the hospital, regardless of what your bed hold policy is, regardless of what your charting policy is, any of those things, when they're going to the hospital, unless you are with 100% certainty that they're not coming back, all hospital discharges should be return anticipated, so that these people are not going to be falling in and skewing your documentation. If you send them to the hospital, you're pretty much expecting they're going to come back. So don't return not anticipated, because when you do that, you're going to have to do an admission if one was completed, as well as skewing some of this data. So people who actually do get this done, the 5-day to the discharge return not anticipated, will be excluded if you have hospice or a life expectancy of less than 6 months. If they weren't admitted directly from the hospital to your facility, so they went home for 3 days, then came to you, they wouldn't count. They have to come to you directly from the hospital or within 1 day. And your managed Medicare people are not to have this 5-day coded. We're going to do it as standalone admission, and that way we won't skew this data. So some of the things you want to consider. Resident self-performance or ability might not be the same on all shifts. At the end of the day, the resident's tired, weak, making them more dependent. Staff have to document what they observed and did on their shift. You have to record the actual self-performance for each ADL and not what we think they could or should do. Now, what causes a problem is that this quality measure is going to be in direct conflict when we're in a case mix state and we're looking for the highest ADL opportunity. All right, we're looking for the most dependent, which is why this is a quality measure that's kind of misleading to the public when they look at this sort of stuff, because we are looking for the most dependent episode in their stay, and it might be because they were sick. If using assistive devices, we want to code performance with that device. For falls, you need to take a look at, are we documenting the level of assist to get this person up off the floor? How many people did that? And then multiple episodes of documentation on all shifts is critical for the accuracy of the MDS. So if we only have once a shift that we're coding these things, you may very well be missing the opportunity to not only capture the highest, but to develop a care plan related on what this patient's actual dependent level is. So a logic check. One of my biggest pet peeves are codings of 4-2 for bed mobility and transfers. I don't understand how somebody laying in bed can be moved 100% of their body weight by one person. Don't care how big the staff member is, don't care how little the patient is. It's not appropriate for one person to be lifting up the entire body weight of someone to move them around in bed. And if they do that, it's not safe for them, not safe for the resident, but you can have skin problems, you have friction and shearing and different pressure, as well as just injuries, bruising. Is a mechanical lift used? Okay, we should be seeing that there's 2 people that are providing assistance for mechanical lifts, unless you have a lift in your facility that the manufacturer's recommendations provide for, and there's been education that allows for this to be maneuvered with one person safely. And then toileting. Why do we have a 4-2 for toileting, but less than that for transfers, when toileting counts with people getting on and off a toilet, bedpan, all of those types of things? The impact of your ADL documentation on the MDS or from the MDS impacts the ADL coding and scoring affects the RUG. The ADL score is based on all of your documentation, not just what comes out of PCC for the CNAs. All right, if nurses are helping, if therapy is helping do something, if activities is helping, all of that documentation, when it's there and in place, supports that. Rehab therapy minutes and their plan, nursing skilled services, cognition and behaviors can all be impacted or a reflection of ADL's improvement or decline. Can impact your quality indicator report and your 5-star rating, as well as survey preparation. So how do you determine if there's a quality improvement opportunity? You need to review your ADL completion and accuracy. Each shift, there should be audits that get done to make sure people aren't going home with missing documentation, to make sure that the things that are coded there make sense to all of us. All right, if we got somebody walking and they don't have legs, that's a problem, okay? We can resolve that before someone goes home. We can question it while someone's there and in real time, instead of waiting for an MDS coordinator to be 2 weeks out and trying to finish an MDS and now finding blank documentation, or expecting that staff is going to recall what they did on a single shift when they've taken care of 20 patients for 7 days, you know, working however long they did. The further you get from the ARD, the less reliable that information is. Completing walking rounds during a shift allows for observation and verification of accuracy coding. So if you have documentation and you review it in morning report today and something doesn't look right, let's go take a walk down the hall and see what did the staff see. All right, maybe they saw something completely different than what it is we see. Identify if the coding is accurate per the RAI manual. Was there just a data entry error? Somebody keyed something in wrong. Was the correct information used for the correct ARD window? So especially in case mix, when we move ARDs around, we want to make sure that we're always using the 7-day look back and that we don't keep using data that was for a tentative ARD and didn't change it. Is missing documentation a factor in your facility? And does staff understand how to code self-performance? You need to know your specs and have your quality measure user manual. You need teamwork. You have to communicate with rehab. You have to communicate with nursing. You have to communicate with different shifts. You have to communicate with the IDT. Share your calendar for care planning so that everyone knows when we're in open windows, and we can be looking for making sure that things are accurate before it gets to the point that it's time to submit the MDS and now everybody's wondering what went wrong. Pull your quality indicator reports and share those with the director of rehab, making sure that they have that and a care plan calendar that allows them to do screens before the ARD that you've already established. That way, if you have to change the ARD, you're not going to have to do an additional assessment. Maybe we can pick them up for something that's a little more subtle this time, so that by the time we get to the next assessment, we're not up 2 levels. We're only up 1 point in 1 ADL right now. Well, that's still time to look at them, so that you don't go 3 months and now you're up 2 points in 3 of them. And then the correlation with the other QMs, so the ADLs, resident triggers for increased help with ADLs. You need to be also looking at, are they triggering for falls, antipsychotic meds, and or pain? Are any of those things interrelated? Did the fall cause the pain? Did the antipsychotic contribute to the complaints of pain? Is the pain causing the decline in ADLs because they don't want to move? Did the antipsychotic med cause the fall? All right, coding for bed mobility and transfers, if you code that 3, 4, 7, or 8, is also a factor in the denominator for risk adjusting your pressure ulcers. So you want to make sure that you're getting that accurate, because then that's going to adjust some of the percentages for your other QMs, the pressure ulcers. And your root cause analysis. Errors on the MDS, are we coding them accurately? Is there a true ADL decline? Do we have a care issue at the bedside, or do we have a new MDS coordinator who's been a little more diligent or less educated on how to code this appropriately? Correlation with other triggers. What's really going on? Once you've completed the root cause, then you can determine what the real issues are and where you should be focusing your quality improvement efforts. And a model for improvement would be, you have to figure out what you're trying to accomplish. We've asked you all to sign in and put down your quality measure star rating. If you don't put it, I'm going to make the assumption you don't know what it is. And if you don't know what it is, then you don't know what you're working toward. Okay, so how are you going to know when you have a change that you've shown improvement? If you're not measuring your data, you're not aware of it, then you don't know what your target is. And then what changes can we make to influence improvement? That's going to depend on the root cause. Did you find inaccurate coding? You're going to have to fix that. Did you identify care issues? You're going to have to fix that. What are those plans to correct and improve those findings?